Hi, Praful.
Good evening, sir. Thank you, sir.
You are live now.
So, good evening, everyone. Good evening, everyone. So, we are here with another episode of our DOS Super Tuesday. So, this Tuesday, we have a topic on dry eye. So, this dry eye clinics, we are going to do at least 8 to 12 webinar series on this topic. And we'll try to teach you starting from basics to a comprehensive approach when a patient of dry eye comes to you. The idea is by the end of this webinar series, at least you people will be able to at least manage a case of dry eye when the patient reports to you in OPD. And the program is oriented and the talks are oriented in such a way that you need not to go through a lot of story, right? Only practical points that will help you in practice. And with our today's speaker is Dr. Divya Manohar, and I'm thankful to her because she accepted this topic in a very short notice. And the tier film basics, all these talks, it's never prepared. You have to say it and prepare, go to the basics. So thank you, Dr. Divya, for that. She is a faculty of cornea cataract refractive Irvine, Chennai. And our panelists for today, our chairperson are Dr. Rishi Mohan. Sir has a lot of experience about dry. Must have heard his expert comments in any of the webinars, CME series, and conferences. Then we have Professor Radhika Tandon. Ma'am is heading one of the cornea unit at RP Center, and she has done a lot of projects on dry eye. Even in Ladakh, people also ma'am has done a project. So again, she has a lot of practical experience about dry eye management. I am going to moderate this session. We have taken participants across India. So Dr. Ritu Nagpal is from New Delhi. She is a faculty at Goela Institute. Dr. Gunjan, again, she is from Delhi. Dr. Rakesh Gupta, he is our own DOS executive member. Dr. Sohini is working at LV Prasad, Bhubaneswar. And Dr. Surbi, again, in Delhi, she is an excellent corneal practitioner, surgeon. Dr. Prabhakar is a faculty. I think Prabhakar, sorry, yeah, if I'm mistaken. So he's a faculty at AIMS in West Bengal. And we have panelist Dr. Shalini Mohan, ma'am. You know her. Ma'am is a renowned face, and she is the SR for me when I joined as a JR at RP Center. Dr. Jaya ma'am, again, vast experience on MGD dry eye. Dr. Rajesh Goyal is from Rajasthan. You know, sir. He's a faculty at SMS Jaipur. Dr. Supriya Dhar, she's a faculty at Army Hospital. And Dr. Parul, again, she's from PGI Chandigarh. She is an associate professor at PGI Chandigarh. So we have taken panelists and discussion across India so that at least our audience can get a clear picture and opinion from across all different quarters of India. So with this, I think let's begin with the talk. The flow of the webinar will be Dr. Dibya will take her lecture, and then I'll go to our chairpersons for their expert comments. After that, I'll request the discussion to share their personal experience, any difficult situation they have encountered, and in the end, go to we'll go to the panelists. The panelists will summarize, or they may give us some different aspects of whatever discussion that we have. So with this, I request Dr. Divya, please share your presentation.
Sure, yeah. Thank you for the very kind introduction, Dr. Prafulla Maharana. And yeah, as you said, it was quite a short notice. Sorry if, my PowerPoint presentations does not meet your expectations. I had to do it at very short notice. Are my slides visible to all of you?
Yeah.
Okay. So I'll be talking about your film basics, the practical points to remember while treating a patient with dry eye. So just for the basics, we all know that the tear film was first, demonstrated by one Fisher in 1928, and then it was coined as the precorneal film by Mr. Wolf. And then He in fact called it, Role actually called it as the superficial or the sixth layer of the cornea. So tear film is important for having good clear vision. It's not just the cornea, it is also the tear film which plays a role in having good clarity of vision. So the tear film consists of three layers: the outer lipid layer, the intermediate aqueous layer, and the inner mucin layer. So the lipid layer is the outermost layer, as I already mentioned. It is about 0.1 micron thick, and it is formed by secretions of the meibomian gland and partly by the Zeiss and the Moll glands. It contains low polarity lipids such as wax, cholesterol esters, and high polarity lipids like the triglycerides, free fatty acids, and phospholipids. The basic function of the lipid layer is that it prevents the overflow of tears, prevents evaporation, and it also stabilizes the tear film, ensuring its integrity and preventing the formation of dry spots. So the middle layer is the aqueous layer, which is again formed from the main and the accessory glands of Cross and Wolfring, and it constitutes the main bulk of the tear film. However, the film covering the corneal part is much thinner in comparison to the film that's covering the conjunctival part. And it contains inorganic salts, glucose, enzymes, proteins, and glycoproteins. The function of this aqueous layer is again to provide oxygen to the corneal epithelium, and it also helps in washing away any debris and irritants that are formed on the surface. It also contains antibacterial enzymes like sublysozyme and beta lysine, which again helps as an antibacterial. It helps to prevent any kind of infections. The mucin layer is the innermost layer, and it is secreted by the conjunctival goblet cells. It actually plays a vital role in stabilizing the tear film. It converts the hydrophobic corneal epithelium to a more hydrophilic one. So it lubricates the ocular and the palpebral surfaces and provides a slippery coating over the ocular surface. It absorbs almost all organic compounds in the tears. So there needs to be a good interaction between the layers. So all three layers have to work in synergy. If one layer is not going to work the way it is supposed to, then it is definitely going to cause some kind of changes in the tear quality. And that is going to definitely cause dryness or other diseases in the eye. So the tear film helps in protection, lubrication, in giving you good clarity and vision, and also acts as a antimicrobial agent. Now coming to dry eye is defined as per the tear film ocular surface meeting that happened. That is the DUCE 2 that happened in 2017. This is the latest definition, which says that dry eye is a multifactorial disease which is caused by the loss of homeostasis of the tear film. So these two terms are very important. So one is it's multifactorial. It's not just one factor that is causing the disease, and also there should be loss of homeostasis of the tear film. Like I already mentioned, there should be a synergy between the three layers for it to function well. And this definition also says that there is instability of the tear film, and there is hyperosmolarity, ocular surface inflammation and damage. So all these terms are literally important, because when we discuss further, we would know as to why these terms are really important. The other one is the Asia Dry Eye Society definition. This is by a group of Asian corneal practitioners who came up with this definition. It's a very strong society in Asia. And they also call it as a multifactorial disease, which is characterized again by unstable tear film, causing a variety of symptoms and or visual impairment, potentially accompanied by ocular surface damage. So talking about the prevalence in India, there are various studies that have been done, and the dry eye disease varies between 18 to 54% in the population. And mobile phone users or visual display terminals are supposed to be the most common culprit for causing dry eyes. And it is also estimated by 2030 that the Indian population, about 275 million people, would be affected, which is quite a huge number. Almost half the population in India is said to be affected, which is quite alarming. So coming to the classification, so this is the Deuce 2 classification, which actually presents a very nuanced approach and recognizes that there is a continuum between the aqueous deficient and the evaporative dry eye. So it's actually a mixed. You cannot separate it as two different entities as aqueous deficient and evaporative. It is more of a combined mechanism that happens. So here the patients are divided into being either symptomatic or asymptomatic. And again, in asymptomatic, if whether there is any signs present or absence of signs, and similarly in symptomatic, whether there is any presence of signs or absence of signs. So this classification also gives us, an idea of conditions like neuropathic pain and dysfunctional sensations, which are otherwise not explained in other kinds of classification that I would be discussing further. So this is basically on the pathophysiology mechanism of dry eye disease, and it also emphasizes on the loss of homeostasis of film, which again includes factors like hyperosmolarity and inflammation. So it is unique because it is talking about neurosensory abnormalities also, which helps us to understand better about the disease complexity. So this is the Asian Dry Eyes Society, which came up with this kind of definition, which is classification, which talks about three types, which is aqueous deficient dry eye, increased evaporative dry eye, and decreased wettability dry eye. So this classification emphasizes on basis of tear film and focuses on the specific problem within the tear film. So this is more like it talks about the mechanical aspects and does not incorporate a severity classification, unlike the TFOS Deuce 2 classification. And this is more practical even in settings where you do not have hi-fi machines to diagnose dry eyes. Whereas with Deuce 2 classification, it's a more robust system of diagnosing dry eyes, and you need a lot more equipments in comparison to this classification system, where all that you need is just a strip of fluorescein, and it can be done in any clinic, even if you're not a cornea specialist, because all that you need is a slit lamp and fluorescent stain. So again, for diagnosing, this is the Tear Film Ocular Society diagnosis criteria, where you have a set of triaging questions. You ask the patient if they have any dry eye discomfort, eye discomfort, and the severity of the discomfort, if there is any associated dryness of mouth or absence of sweat, how is the vision? You ask them such questions, probing questions, use of contact lens for a long time, ask such questions and then analyze, and then you do the diagnostic test. You also have the questionnaires like the dry eye questionnaire and the OSDI scores, which can be used to get a conclusion of what kind of dryness the patient is suffering. And then you also look at the homeostasis markers like non-invasive tear breakup time, osmolarity, ocular surface staining, and then classify them as either being evaporative or aqueous deficient. And so here, if you're going to do these multiple tests, then you always have to make sure that the first one that you perform is the non-invasive breakup time. Then you do the osmolarity testing if you have it. Then the fluorescent breakup time and ocular surface staining. So this is the order that you follow. Before you do any staining, you want to finish all the non-invasive procedures and then proceed to the invasive procedures. So in examination and investigations, so this is very important, a thorough examination, and history taking is also equally important. So once you've done a good history taking, do a thorough examination of the ocular surface and the lids. So first, this is a technique where you use the look, lift, pull, and push examination. So look at the patient's blink quality. So this gives you an idea if there is a partial blink or incomplete, or whether it is a complete blink. So that will also help us to know if the tears might be produced well, but the patient might not be blinking properly. So that might again lead to dryness. So look for the quality and the quantity of blink. So roughly about 15 to 20 times per minute, especially when using gadgets and laptops. With a lot of computer professionals walking into our clinics, we see that they start staring at the monitors, not blinking adequately, leading to dryness. So make sure that they blink well, and examine any eyelid malpositions or lag of thalmos. Nocturnal lag of thalmos is another question to ask patients, because that by itself can cause a dryness. Again, proptosis, any trichiasis that you notice, look for the tear meniscus height on the slit lamp. Look for any blepharitis, demodex, or meibomian gland dysfunction. So all these can give us a clue as to why there is dryness. Again, the next step is, after looking, you lift and pull. So this will actually expose any SLKs or any corneal scars, which again gives us a hint that there is some inflammation happening there. And you can also look at the lid laxity and floppy eyelid syndrome. So the other thing to look for is conjunctivochalesis, where there is excess tissue of the conjunctiva that can also lead to dryness. Again, push, this is to express the meibomian glands. You can see how well the meibomian glands are secreting sebum. So that will also give us a good idea of about how the meibomian glands are secreting meibum. So that will tell us whether the patient has any meibomian gland dysfunction there. So again, as I said, good thorough eyelid margin examination. Look for any thickened or blunt eyelid margins. Look for keratinization of the eyelid margins. Again, patients can present with demodex and also blepharitis. They might not even be aware of it. So if you have a slit lamp with a good camera attached to it, it is always good to click a picture and show them how it is, or at least on your phone, because a lot of times they do not believe when we tell them that they have dandruff-like material sitting on their eyelid margins. So it is good to educate the patient about their eye condition. Again, look for meibomian glands, hyperemia of the eyelid margin, plugging repeated infections in the corneal surface. Then again gives us an idea that there is some inflammation happening there. So again, look for lid wiper examination. This is by using a fluorescent strip. This is by using a lissamine green strip, where you actually look for how the lid margins are. So this basically, what happens is, because of keratinization of the lid margins, every time the patient is going to blink, or every time he's going to open and close his eye, there is some kind of rubbing that happens on the corneal surface, which is going to cause irritation and PE's kind of picture. So when the staining length from the pictures here, you can see that when the staining length is more than 2 millimeters or more than 25% of the lid margin, then it is considered positive for lid wiper epitheliopathy. So this is something that you can do in your regular clinics. This is the invasive TBAT, but this was actually, this came up from the Asia Dry Eye Society, which classifies the disease based on just the fluorescent staining pattern. So this is called the tear film oriented diagnosis. So this is very straightforward and can be done in any clinic using just a fluorescent dye and the blue light on. So this actually eases the use of doing the test in any clinic. That is the beauty of this. So in severe aqueous deficient type of dry eye, you see that there is almost no aqueous layer. And even with blinking, it does not form a tear film. So here you'll have a area break. So in case of decreased wettability type, where when they open and close, you would see a spot break. In the aqueous deficient type, a linear break occurs at the inferior part of the cornea. And when the aqueous layer is pulled by the lower tear meniscus, you can again see a line break. So in case with mild decreased wettability, vertical line like breaks occur. And when they move upwards, again, fluorescent stains the aqueous tear. So there you can have a dimple break. So again, random break is caused by thinning of the tear film due to the aqueous tear evaporation. Once the fluorescent moves upwards. So basically you have an area break, a spot break, a line break, a dimple break, and a random break. And this gives us an idea of what exactly is happening there. So if it is aqueous deficient, then you have an area break. When there is a decreased wettability because of mucin deficiency, then you see a spot break again. So increased evaporation, you see a random break. So this gives us a clinical picture, of what kind of dryness that the patient is having, what layer of the tear film is actually compromised there. So this is a very easy thing that can be done in any of our clinics with just a fluorescent strip. So this is what I was mentioning about. So I think I've already discussed about this. Next is the ocular surface staining, where you stain the ocular surface. So you can use both sodium fluorescent 1% is usually preferred for the corneal staining. So it basically involves dyeing all the corneal defects through diffusion of the fluorescent cells between the cells into the adjacent intercellular space with penetration into the lower stoma. So healthy corneal epithelial cells are not stained. Only those with defects are able to get stained with sodium fluorescence. And since because of this reason, we are able to pick up diseases like which have corneal abrasions and any erosions or epithelial injury that is happening because of dryness. Whereas when you use the rose Bengal stain, it is usually preferred for the bulbar conjunctival staining. It does not stain healthy epithelial cells because of the obstruction of an intact ocular tear film. So, but however, this rose Bengal stain can be a little cytotoxic, and patients can feel a little tingling and burning sensation. So it is always good to use an anesthetic drop when you're using the rose Bengal stain. And again, lissamine green staining is very similar to the rose Bengal stain. And as I said, it can be used to look for lid viper epitheliopathy. However, it is lesser cytotoxic in comparison to the rose Bengal stain. And both these rose Bengal and the lissamine green stain give us an idea of the mucin levels. Shermer's test is something that is performed in most of our clinics. Again, not a hi-fi thing. It's just a Whatman filter paper, which is about 5 millimeters wide and 35 millimeters in length. It has a notch at the tip where you just bend it and put it on the lateral aspect, 1/3, and the medial 2/3 junction of your eyelid margin. And then you look for the tear levels in it. So this can be performed either with an anesthetic, where it is called the Shermer's test 1, where it actually looks at the baseline secretion that is happening. And the Shermer's test 2, that is without an anesthetic, where it gives you both the baseline and the reflex secretion. So again, the strip meniscometry, this is, it's a rapid test for assessing the tear production. So the center part of the tip is held and the tip is immersed into the tear meniscus of the lower eyelid for about 5 seconds to absorb tears. When the strip color turns to blue, it indicates the volume. You have markings there, which gives us the thing. So again, when it is when the strip measurement is equal to or more than 5 millimeters, then it is normal. And when it is less than 5 millimeters, patient has dry eye disease. Again, this gives us a value of how good the lacrimal glands are functioning. Tear meniscus height, this can either be measured on the slit lamp using fluorescent staining. In the lower picture where you see, you can actually measure it using your slit lamp, and you can turn on the measurements and see what level of tear meniscus height is present. Usually about 0.3 to 0.5 millimeters is considered normal. And you can also use something like an OCT machine, where you can look at the tear meniscus height if you have access to one of those machines. Tear osmolarity, again, this is a gadget that gives us an idea of how the tear osmoles in the tears are. If it is going to be dense because of less aqueous, then again your levels are going to be high. And an inter-eye variation of more than measurements that is more than 300 milliosmoles demonstrate that there is a loss of homeostasis in the eye. And also an inter-eye difference with more than 8 milliosmoles per liter gives us an idea that there is definitely some inflammation that is happening there, and there is instability in the tear film. Again, you have these MMP9 markers, which are nothing but they are matrix metalloproteinases, which is an inflammatory biomarker again, and it is shown to be elevated in patients with tear deficiencies or with dry eyes. So I do not have access to this. I haven't used it. I'm sure someone from the panel must have used it because it's quite popular and available widely. Again, tear film breakup time, you can either do the non-invasive or the invasive type of tear breakup time can be looked at. So tear breakup time under 10 seconds is considered abnormal and is indicative of dry eye disease. We have access to these machines where the tear breakup time is non-invasive and it is picked up by the machine itself. So again, interferometry, this is also done by the mammography machine, which gives us the idea of how the lipid layer thickness is, and it can help us in diagnosing meibomian gland dysfunctions. Again, this gives us a picture of how the ocular structure or the of the meibomian gland is, how the structure is, if it's tortuous or if it is good, how it is going to function, and also the number of gland dropouts. Everything can be picked up with a mammography. There are also certain ways to pick it up, even if you don't have a mammography machine. Just autorefractometer is supposed to pick up meibomian gland dysfunction. When you invert the lid and look the patient on an autorefractometer, there are a few reports that say that you can pick up meibomian gland dysfunction in that as well. Again, conjunctival hyperemia analysis, this can also be looked at on a slit lamp. You don't need these hi-fi machines, but this is just one of the features of the machine. Again, confocal microscopy, unfortunately, they don't produce confocal microscopes anymore. So those who have access to that, it is a good way of looking at how how it actually works, the cellular matrix, and how the basal plexus nerves are actually functioning. So you can actually have if you have an access to it, it's a good way to look at it. Again, ocular surface analyzer, as I said, this is, you can see that it comes with the gland markings and you know how well your glands are functioning. Again, it measures the tear meniscus height. The ocular surface, I'm not sure if the video is playing, yeah. But the ocular surface analyzer also gives us an idea of the blink rate. So as it is capturing the other data, it also measures the blink rate. So if you have an access to ocular surface analyzer, it gives you all in one, but it is quite expensive. You don't need all this, even without hi-fi machines like this. Just a good slit lamp examination and looking at the patient closely and asking them for a good history can give us a lot more clues. So yeah, as I said, again, NEPAT. So this is the report that we get from an ocular surface analyzer. So it gives us all values like as to what was the non-invasive but time, again, eye blink rate, lipid layer thickness, the tear meniscus height, if there is any kind of meibomian gland loss in the upper or the lower portion of the eyelid. So it gives us an idea, and then it is having a report like this makes it easier for us to make the patient understand the type of disease that they have. And this works more in case of meibomian gland disease, then it's very easy for us to tell the patient that this is what is happening. So coming to the treatment part of dry eye, the goals of our therapy is definitely to make sure that the patient is relieved of his discomfort, to provide a smooth optical surface for a better and a clearer view of what the patient sees, and to prevent structural damage to the cornea. Some of the general measures that we can tell patients is to avoid being in dry atmospheres, like in a air-conditioned room for quite some time. And if they have to be in a room for a longer period of time, it's always good to use a humidifier and to avoid direct blasts of heaters, air conditioners, or even fans. So using wraparound glasses or lid hygiene, all these are something that you can actually educate your patient about. So systemic therapy again is indicated in very severe conditions like OCPs. And you can also ask history of whether patient is on antihistamines, which is supposed to reduce the secretions. Again, artificial tears, ointments, secretagogues, vitamin A enhanced ointments, therapeutic soft contact lenses. So all these are some of the medical managements that you can provide for your patients. Again, surgical management is when punctal occlusion, especially when you want to retain whatever tears you're going to instill in the eye, or in conditions where there is tear production, but somehow, you want to keep that there, then you want punctal occlusion to be done. Tarsorrhaphy or taping, especially for patients when they have nocturnal lag of thalamus or just lag of thalamus. In those conditions where you want the eyelids to be closed well, you can always do a tarsorrhaphy or taping of the eyelids. And again, MMG, transplantation of parotid duct, these are in very severe cases. So supplementation of tears in the form of either drops, ointments, or gels, or inserts to hold the gel in, to hold the tears in place. So artificial tears, as we know, is to stabilize and thicken the precorneal tear film, and it also prolongs the tear film breakup time, keeps the ocular surface wet and lubricated, and helps to repair any ocular surface damage. But however, ocular surface, the artificial tears that we use cannot completely replace the natural tears that are formed. There is definitely going to be some drawback of using artificial tears. It is not going to be 100% like what your natural tears are. So I think want of time, let me skip to all. Okay, so hydrogels again are they are viscosity enhancing agents that are used in artificial tears, and they make it more viscous so that they can stay on the eye for a longer period of time. So what exactly it does is it swells up in water and retains moisture for a longer period of time, and help and stays and makes the patient feel comfortable. So these are some of the examples of hydrogels. And again, ointments and gels, they are used very commonly after artificial tears, and they get dissolved at a temperature when they sit on the ocular surface and disperse with the tear fluids, and retention is for a much longer time in comparison to drops. So again, to preserve the existing tears, as I said, you can use bandage contact lenses or goggles, or also using punctal occlusion plugs. So these are some ways where you can preserve the existing tears. Stimulation of tears, you can use secretagogues. Oral pilocarpine is being prescribed by a few doctors across, and they seem to be doing well with oral pilocarpine, whereas my experience with oral pilocarpine is very limited. Again, dispersal of mucin is by using 10 to 20% acetylcysteine, which comes in a lot of eye drops that you get. Again, anti-inflammatory, you want to control the inflammation that is happening in the ocular surface before treating patients with dry eye. So you can use medications like cyclosporin and tetracycline. Now you also have previously 0.05 and 0.1% were available. Now you have those 0.01. Now you also have the 0.09%, which is quite comfortable for the patients. Again, corticosteroids, as I already said, low-potent corticosteroids like lotepred is my favorite. So always start the patient on loteprednol, start them on a course of loteprednol for at least 1 month in tapering doses. Make sure the inflammation is under control, and then you can start either liftigras, which is a very new molecule for the Indian market. I have no experience with it yet. It is just being launched, and I heard it is quite expensive also. So I'm not sure how many patients can actually afford it. But you can always give cyclosporins, which are equally good. So this is the Tear Film Ocular Society dues to management process. So as I already mentioned, you have the triage questionnaire, you analyze the factors, you do the diagnostic test, and then you classify them as either evaporative or aqueous deficient dry eye. And depending on the severity, you treat them stepwise. So step one is basically educating them, identifying what is causing the dryness, avoiding those factors, and giving them ocular lubricants, and lid hygiene and warm compresses in cases of meibomian gland diseases. Again, step two is when the step one doesn't work, then you go for step two, where along with tea tree oil again is used in cases of Demodex. So that is one thing that you'll have to look for. These are available commercially in the market. Any beauty store that you go to, they have shampoos with tea tree oil. That is, you can ask them to use it around the eyelids, massage it well, and also do hot compresses in case of meibomian gland diseases. Again, moist chamber glasses or spectacles, which are available commercially on all the websites like Amazon and Flipkart, which a lot of patients use, and some people are really comfortable with those. Again, punctal occlusion can be done, and to give them ointments, especially at night, because you want more moisture to be retained. Your eyelids are do not open and close when you're sleeping. So there is no tears that are spread. So it is good to give them ointments at night. Again, you can start them on topical steroids, secretagogues, and oral macrolides or tetracycline. So again, things like, drugs like macrolides, they are not just and they're antibacterial, but they also have a role as an anti-inflammatory agent. So it is good to start them on oral macrolides as well, or tetracyclines. And again, if that doesn't work, then you start them on autologous or allogenic serum eye drops. And again, bandage contact lenses or rigid scleral lenses. And the final step, when the disease is really severe and out of control, that's when you think of amniotic membrane grafts or other procedures like the salivary gland transplantation and tarsorrhaphy. The Asian Dry Eye Society came up with this tear film oriented therapy. They did the classification depending on the fluorescent breakup time, and also did the tear film oriented therapy, where basically when there is a lipid layer deficiency, their therapy is warm compresses and lid hygiene, low dose ophthalmic ointments, and diclofenac sodium, which is not available in the Indian market as far as my knowledge goes, which is supposed to be something like a secretagogue. So it helps in tear production. Again, when there is aqueous or mucus layer, artificial tears and sodium hyaluronate. Sodium hyaluronate is the newest in the artificial tears range, and quite a favorite of mine, because it has sodium hyaluronate basically has more moisture retention property, almost 10 times more than what the size of the molecule actually is. So it's quite comfortable to the patients, and it is not highly viscous. Patients are quite happy with sodium hyaluronate. I have no financial interest, but just talking out of my experience. And again, when there is ocular surface inflammation, as I already mentioned, you want to bring down the inflammation for the other medications also to start acting. So in case you're starting a patient on cyclosporin, it's always good to give them a short course of steroids, and then along with it also start them on cyclosporin. So this is again the same thing. So this is basically a very small, a simple way of looking at it. So the outer bronze ring actually gives us on how to go about, when there is a very simple problem, like looking at the blink rate, asking them to blink frequently, take short breaks in between artificial tears to avoid contact lens for a long time. And the middle silver ring actually gives us more moderate treatments like basically against scleral lenses, intense pulse light therapy in case of meibomian gland diseases, or the lippy flow, where it actually massages your meibomian gland along with, it expresses out the meibum from the meibomian gland. And the inner gold ring, which is more complex treatment like punctal plugs or other kinds of surgery. So this is a simple dry eye wheel. This, as I already said, so even surgeries, asking history of surgeries, patients might not reveal any history of surgery, but even surgeries can actually alter the ocular surface, especially when they have undergone refractive surgeries, laser vision correction. When you have surgeries like LASIK and PRK. PRK is definitely better in comparison to LASIK, or and SMILE also is supposed to be good. So you also have to ask them for surgeries. So to summarize, the diagnostic evaluation of dry eye disease should include a very detailed patient history, a thorough slit lamp examination, and also look for ocular surface staining. And if you have an ocular surface analyzer, it can be used to evaluate not just the quantity, but also the quality of tears. And so there has to be a comprehensive approach, individualized care, treat the patient, not one drug works for all patients. So you have to kind of tighter the drugs as per the patient's needs. One patient who's happy with polyvinyl alcohol might not be, so, might not be happy with sodium hyaluronate, the same patient. So you have to talk to the patient with when he reviews with you every time, find out what molecule suits him the best. So that's how you need to to monitor your treatment and also to modify your treatment. Thank you for your time. Thank you for the opportunity as well.
Thank you, Dr. Divya. That was a comprehensive presentation of how to diagnose and manage a dry eye patient in OPD. Before going on to our chairperson, I have one question. Are there, see, when a patient presents to you in OPD, all of us may not have the access to OSA or all these investigative tools. When a single practitioner sitting in OPD, a patient comes to him, what are the basic tests that he can do so that he can pinpoint, okay, my patient may be having aqueous deficiency, or this patient may be having mucin deficiency, or maybe mix or lipid deficiencies, which are the common tests that one should do in an OPD?
Yeah, so that is what I mentioned, the tear film ocular diagnosis. The fluorescent strip that you use gives us an idea of what kind of deficiency is there, whether it is, there is evaporative dryness, or there is using the break, whether it's a dimple break, a line break, or a spot break. That gives us an idea of whether, a rough idea of whether it is mucin deficient or lipid deficient or aqueous deficient.
Thank you. Then I'll go to my chairpersons, Professor Radhika ma'am and Dr. Risimohan sir. Sir, your take on the lecture and what are your basic tests that you would recommend to practice as OPD, so that at least they can get a guess ki, okay, this patient may be having this TFM lead deficiency.
Go ahead, Radhika. You want to go first?
Okay. Thank you, Praful. And firstly, it's a very good initiative of DOS to have this kind of webinar, and this topic is extremely important. Dr. Divya very nicely covered all important aspects and gave a very comprehensive, full overview about the subject. And as you asked, Praful, what practically is important in the OPD, is firstly the realization that there is a dry eye, and often the patient may be coming with some unrelated symptoms, and you have to make it a point to always look for this condition because it's quite rampant. So when you're looking on the slit lamp, it should be part of your normal protocol to at least have a look at the way the ocular surface looks and the way the tear film looks. So that's the first thing, to be aware that it is there. Some patients may be having symptomatic dry eye, and some patients may be having dry eye which may not be picked up, and if you miss this, it may affect your other next steps. For example, if you're planning a prenatal cataract surgery or even refractive surgery. So it's not always that the patient will give you symptoms which will indicate that there is an underlying dry eye. Largely, as Divya said, you will do the assessment, and the fluorescein staining is very useful, very simple tool that is available to everybody, and it doesn't take time. And then, depending upon how much you want to quantify it, then you will go further with other tests. And if supposing the patient is very symptomatic and we want to document, then of course one would use the higher end test, which is ocular surface analysis, tear osmolarity. Shermer's is something which may not always be very practically useful. So the TFOS triaging is a good way to follow. And a single two important things I would say: an OSDI assessment, OSDI questionnaire, and the fluorescein staining.
Thank you, ma'am. Rishi sir?
Well, yes, I totally agree. And I must thank Divya for an excellent overview. She's been like a very good quality tier film, covering all the subjects very nicely. So yes, I agree. And the whole thing, I think, largely is observation and listening to the patient's complaints. I think that's the key thing. We sometimes just get carried away. We don't listen to what he's saying. And also then sometimes just simple questions about what time of the day are your conditions worse, simple things like how much of screen times do you have, what's your professional requirement, how often do you get breaks from screens and all. I mean, small things sometimes can give it away. And then, of course, the question of doing a good exam. And the exam does start from just watching him as he comes in, and the blink rate, um, and then the way he sits, the conjunctival film, just the way he blinks. These are just small things that give it away. And then, of course, then the quantification and then the qualification of the kind of dry eye will depend on some of those tests that we've already looked at. My favorite tests are, of course, of ocular surface staining. Again, as Dr. Radhika mentioned, Shermer's has fallen off as one of the tests that we used to do earlier. I remember in our earlier case sheets, it used to be printed. Now it's not printed anymore. We write it when we want it, and we ask our techs to do a Shermer's. So I think on the whole, we have come a long way. We are actually, I think in my practice, I'm probably seeing over-prescribed and over-diagnosed dry eyes rather than under. Even all, I think the overall data nationally would suggest that we are still under-recognizing it. But I think that may be coming from the rural areas. I think in urban communities, we are probably over-treating it. Everybody who comes in, regardless of what he has or doesn't have, is on a lubricant. And sometimes I wonder if that's overkill. Anyway, so I'll let this discussion go on in Praful's expert's hands, and he should take it forward with moderating the session. Thanks very much.
Thank you, sir. And Dr. Divya, you showed a nice slide where you the TFOT or tear film oriented therapy, where when lipid-led deficiency was there, it suggested warm compress and sac massage lid hygiene. And there was a drug diquafsol sodium, which is
Yeah.
not available in India. So my question to chairperson as well as panelist: when you suspect the patient is having lipid deficient dry eye, what are your preferred molecules? Somebody sitting in OPD, what molecule he should choose to treat such patients where the deficiency is probably lipid-led? Radhika ma'am?
Okay, so yeah, so firstly, when there is a lipid layer deficiency, firstly try to see if you can identify a reversible cause. Look at the meibomian glands very carefully and treat the MGD with the usual treatment of the hot warm compresses, hot fomentation, mid massage, and hygiene. Then you have to, because that is the cause, you have the blocked ducts or there's a poor quality lipid, and that is setting off the vicious cycle. Apart from that, if there, in order to supplement the lipid, we do have liquid paraffin preparations in India. So that is liquid paraffin eye ointment in the form of certain brand names, like we have Aqualute PM, Softcute PM, Evolve. PM, I think, again. They all call PM because they are all put at night before sleeping. So we do have the liquid paraffin products available. Apart from that, if I'm not mistaken, one of the Sustain products, perhaps Sustain Complete, has a molecule which is supposed to supplement the lipid layer. I'm just mixing up whether it's Sustain Complete or Sustain Hydration.
It's complete, ma'am. It's complete.
Yeah, so Sustain Complete is a good one to use if you want to give a lipid replacement specifically. But I would again emphasize that the taking care of the MGD is important, because otherwise they are prone also to get infections and painful hordeolum internum, etc. So you need to take care of that as well, and I think that should cover it.
Thank you, ma'am. Rishi sir, your preferred choice, or you agree with ma'am?
I don't think there's much to add beyond what Dr. Radhika has said. I think heat is the primary treatment for anything that is oily. We need to soften it and then extract it. And I think that's where we sometimes just give heat without actually teaching the person the right way to do the massage. And if that is not done, it's just like heating and cooling, and that's it. I mean, so nothing's going to come out unless you teach the person a massage and a scrub. So amongst the scrubs, of course, there are many options. Again, tea tree oil is gaining favor, but I still prefer my oldest technique of diluted betadine. I still think it's a brilliant product, and povidone iodine helps to restore the balance, and so that can be initiated. Then, of course, there are molecules like tetracyclines and some macrolides which can be given, which will help improve the MEBM score. Again, Dr. Radhika correctly and rightly mentioned whether it's a hyposecretory kind of a MGD, and then we have to look at it from some stimulatory treatments as well, other than just heat compressors like LipiFlow or an IPL. They do, I think, at least 70% of patients have a pretty positive response to those things. So that is it. Basically, I think evaporative eye dry eye is more common. We do appreciate it, that it's commoner than just a pure aqueous deficiency.
Thank you, sir. Dr. Shalini ma'am, how frequently you think in your practice or in your area you feel the lipid deficiency is the primary cause of dry eye? And what is your approach? You do like to add something other than what Radhika ma'am and Rishi sir said, or you also follow the same treatment plan?
First of all, I would thank you, Dr. Praful, for this wonderful initiative, and Delhi Ophthalmic Society also for making me part of this also. So, Dr. Radhika Madam and Dr. Rishi sir, whatever they have said, that is actually the protocol which we have been following, and we learned there also, and we are following it routinely. Regarding the thing that how frequently, in our scenario, that is very, very common because of poor hygiene, because of the patient's profile who are coming from far off places, especially rural background. So this type of dry eye is extremely common with us. And as Dr. Rishi sir said, that many a times they don't even know how to express it out. So teaching them nicely to giving warm compresses and then expressing it out. In fact, several times we have to teach them many times whenever they are coming to our OPD. Still, we feel that they are not doing it in a correct way. So that is, I think, this education is very, very important, how to express it out. And then I definitely add tetracycline or doxycycline to these patients. For at least a month's therapy, I give them. And along with this, yes, liquid paraffin ointment is the choice. And tea tree oil, I'm not using that much in my practice. But yes, hot compresses with betadine is the thing which I advise to my patients. And that is actually a cheaper option also. Many a times because the wipes of tea tree oil are a bit costly, so patients might not be able to afford, and then they discontinue using it. So not in every cases, but yes, if patient is affordable, I do advise those things. And then I don't know, I don't have much experience with LipiFlow, and I would also request the panel and the chairpersons to tell us a bit about LipiFlow, whether it is actually that beneficial, that it is so costly also. Per sitting also, it is definitely costly. So should we have that in our clinical practices or not? I would request panel to answer that.
Okay, I'll go to chairperson for that questions. Before that, I would like to ask Dr. Parul. Dr. Parul is from PGI Chandigarh. What is the patient dry eye profile in your setup? Because it's another tertiary care center that gets a lot of referral. So, Dr. Parul, how frequently you see aqueous or mixed deficient dry eye or lipid deficient eye? And what is your approach at your center?
So lipid deficient dry eye, that is evaporated dry eye, is very much prevalent. It is much more common than the aqueous deficient dry eye. So aqueous deficient dry eye we mostly seen in the primary or the secondary Sjogren's patients, and especially I look at many Steven Johnson patients also, as well as ocular cicatricial pemphigoid patients in their later stages. So even in the clinical examination, there is a very important point which needs to be added, that there is a test which was given by Dr. Basu et al. That was a direct assessment of tear secretion. That is a DATS test. So that is a very simple clinical test we can do in the OPD. In that, we just evert the upper lid and go to the lacrimal gland and just touch the lacrimal gland with the unstained, not wetted fluorescein strip. And if we see 3 to 5 points of fluorescein emitting out of it, that means it can be a normal person's eye or it can be evaporative dry eye, because the meibomian, because the lacrimal gland is normal in a MGD patient. Whereas in an aqueous deficient dry eye, we will not see those points. So especially in a cicatricial conjunctivitis patient like a Steven Johnson patient or a Sjogren's patient, we will not have those points of emission of the speculation from the fluorescein. So DATS is a very important test which can be added to our armamentarium, and a very simple test. And lipid deficient dry eye can also be treated by these oral macrolides. Like we can give topical macrolides, but the oral macrolides, there has been a study in which they have given 1 gram of azithromycin per week for 3 weeks. And they have compared it to 6 weeks of oral doxycycline 100 mg BD. So they found an equivalent result. So compliance-wise, I think azithromycin is much better. And it doesn't have a very severe gastrointestinal side effect profile also. So 1 gram per week for 3 weeks can also be added to the treatment regimen.
So this 1 gram is
Oral.
either divided in 500 BD or you are giving
oral.
start
Single dose once per week. Only on one single day for 3 weeks.
So now I would like to go to Dr. Rajesh, because Dr. Salini is from UP. Now you are from North. Now let's take a view from Rajasthan also. Sir, what is your patient profile in your setup? How frequently you see lipid deficit or aqueous deficit dry eye? And what is your approach there? Dr. Rajesh? He's not there. He was joined us. I think he has left probably. So then let's get back to our central Delhi. Dr. Jaya Gupta and Dr. Surabhi Dutt both are from Delhi. So what is the patient profile that you see in your setup, and what is your approach for lipid deficit dry eyes patients?
Specifically
Jaya
for,
ma'am?
right. So you want to know specifically for lipid deficient, the evaporative dry.
What are the proportion of aqueous deficit or mixed dry eye and lipid deficit dry eye in your setup? And yeah.
Yes, I'll agree with Parul. Our setup also, we have more of lipid deficient or evaporative dry eyes, because obviously the digital eye strain, these are the patients that we are seeing more often. But being a cornea specialist, I do get a lot of referrals from the rheumatologists and the immunologists. So I do see an equal amount of aqueous deficient dry eyes. So a little like the treatment obviously differs a little in the sense that aqueous deficient is a little difficult to handle. Lipid deficient or evaporative dry eye is relatively simple in the sense that we can teach the patients how to improve the symptoms and what are the things that they can be doing to basically get relief from evaporative dry eye. So Dr. Shalini had asked a question about LipiFlow. Maybe someone else can also answer that, add to it. LipiFlow is expensive, but there are, ma'am, many other devices which I think Dr. Divya had only mentioned that OSA from Zebra, so that is for the analysis part, but then they also have this IRPL or iLight, and then there are other things like IPL, that's from Tosh Pro, which are equally effective and not so expensive, that just cost 3,000 per person per, I think, treatment. I think that's the cost for IPL from Tosh Pro. And iLight is iLight, and IRPL, that is from
EI.
that's a little bit more expensive, probably 8,000 or so. But the first sitting is not so beneficial, but after the second sitting, they are usually quite comfortable, and that basically is supposed to stimulate the parasympathetic nerve supply. That's the hypothesis, I think, that's there for IRPL, isn't it?
Yes, ma'am. So we have the IRPL, and what we have found is it is quite efficient in patients with early MGD, early to moderate, mild to moderate. Very severe cases, that doesn't work as well.
Absolutely. So you need to express it out after that IRPL treatment also, that those
kind of massage it.
it needs to be expressed out. So like, I mean, along with that, the warm compresses has to continue.
Yeah, so it's just an adjunct, one of the, adjuncts. So just that
Thank you,
will.
ma'am.
Yeah.
Dr. Survi, what's your experience on this IPL, all this
So
pulse
I
therapy, heat therapy?
So I don't have any of these in my OPD. So if I have a patient, it's a simple thing that if I have an ARK machine, I just simply flip the lid and you get an image. So it's a very simple tool. On the ARK, you get the meibomian graphy type of infrared image. And from there, I just take a print and I show to the patient that, look, this is most of the patients which come into our OPD is actually the computer, the people who are in the office, and most of them. Of course, we do get all the other severe cases, but if you have to look at the most common entity, it is going to be MGD. It is going to be the cause of most of them. And if you have to make them understand that why is it important for massage and the frequent breaks from computer and all that, you need to depict it to them because most of them do not understand it. They just feel that we're just actually just giving them drops, telling them hot compress, and telling them to go away. But it's not that. It is the most important treatment for this class. So it's important that if you can just take a photo, even if you don't have a printer attached to the ARK, ask your assistant to take a photo, show them on the phone. It's as simple as that. Most of them really understand and they follow it. And of course, the way to treat it is, of course, to physically show them that you have to massage, activate these glands, good heat compress. It's very important. And of course, the added on things which are there.
Thank you, Dr. Surmi. Radhika ma'am, so what's your opinion when one should decide to go for this heat therapy?
Here I will say that you had asked firstly about LipiFlow. So LipiFlow is a very good device. It's a very good therapy, and it actually is giving a very gentle heat and a gentle intermittent pressure, just exactly the way it's required by pressing inside and outside the lids. But of course, the downside is that it is expensive and it takes time. So I would say that if one is in a setup where it's affordable and it's a treatment that you can, just 1 second, huh? So if one has a setup and one has patients who can afford it, then it is a good treatment to have. But at the same time, the question is how much, whether you should purchase it, whether you should invest in it. And I would say that if you use the same principle that you get with LipiFlow and apply it, that is equally good. And often, some people are very elderly and they may not have the people at home to help them, or they have their fingers and all are not that subtle or not that agile to do it themselves. So if you have a clinic where you can spend a little bit of time and do it for the patient, long ago we used to just do it with a simple lid spatula, and against a spatula one would just express it out, or whichever technique. But the main problem is ophthalmology clinics are now so busy and the ophthalmologists don't really have the time to take that. So you can consider it as a kind of a therapy or a kind of a procedure and schedule it for certain patients. And then once you do it for them or show the relative, it may take an extra 10 minutes of your time, but then they can do it themselves. So therefore, I would say that you have to have a mix and match policy. Definitely, these various devices are very good tools, but they're very, very expensive, and it's not very practical to put them in routine practice, and we have to be conscious of that. So one can, incorporate the principles of these devices and then try to do the best for the patient with whatever is available.
Thank you, ma'am. Just to add one point here, recently I was judging a free paper session and somebody was presenting a paper. They simply purchased some mask from Amazon and then they have built their inbuilt heat therapy with that, which is very cost effective. So the idea is to give heat to the meibomian gland, and the only thing is that temperature has to be somewhere between 40 to 44, and that should not be transferred to conjunctiva or else it may damage the conjunctiva. Any device that can give you that that is useful. That is a useful tool. So I'll go to the next part of this webinar, which is with our discussion. So I will go to the discussion one by one. Dr. Gunjan, first, would you like to add anything to whatever discussion that we have? And would you like to ask any specific questions to the experts?
Uh, Thank you so much, Dr. Praful, for giving us the opportunity to be here. And it's very nice to hear everybody talking about this disease, because now a lot of people are suffering from it. And I do agree with Dr. Rishi sir about this overkill part, that a lot of patients do come up with this Google diagnosis, or just because somebody has given them a lubricant, they start imagining that they have dry eye, and they start reading over the internet, and they think that they are suffering from a very major disease. So first of all, that is really important for us as an ophthalmologist to first identify whether the patient really has a dry eye. And also, one of the most important thing that now a lot of people are coming up with allergic conjunctivitis. So allergic conjunctivitis patients, sometimes they also feel that they have dry eye. So that is also our motive also, and as a clinician, that are we really dealing with dry eye in such patients? So that's also very important. So I would like to ask all the panelists and chairpersons here, how do you deal with patients who are having chronic allergies? Do you, just tell them that to exposure should be avoided, or anything else you go ahead with in such patients?
Gunjan, sorry, I missed that question. Any of our panelists want to take that?
Yeah, so for chronic allergies, we first of all give the routine advice that avoid the allergens, and wear goggles to avoid the pollen and the dust. And later on, with the routine medicines which we give, that is olopatadine, which is a dual acting agent, antihistaminic as well as a mast cell stabilizer. We give that with the cold compresses, and some oral levocitrazine type tablets to decrease the allergy part. And of course, we tell the patient not to rub. And a very, very important component in chronic allergies to be added is the topical immunomodulators, like the topical cyclosporin 0.05% or 0.09%. And even better than that, that is 100 times more efficacious is the topical tacrolimus ointment. So we typically use the 0.03% ointment. It can be used inside the eye, but if you want a stronger action, we can also use 0.1% tacrolimus ointment, which is a skin ointment, and that can be applied over the eyelids twice a day. So that also helps in modifying the disease. And if the patient still is not comfortable with that, we can also progress on to oral cyclosporins or tacrolimus. So the problems with oral cyclosporin is, especially in girl child with VKC, oral cyclosporin leads to a lot of gingival hyperplasia as well as hirsutism, so which is not desirable. So a better option and a cheaper option would be oral tacrolimus. So oral tacrolimus has a very good profile for patients who are not responding to the routine medications. And if the child has a chronic giant papillae, we can always shave them off. Or in the later stages, we can also do a mucous membrane grafting, because a mucous membrane from the mouth will not have the same reaction that the palpebral conjunctiva has. So you will never develop papillae in the bulbar mucosa, in the MMG which we transplant. So that is in the final stages. So this is the protocol that we follow.
Any of the panelists like to differ from Dr. Parwar, wants to add anything? By the way, we will have a different webinar, separate webinar for this allergy and dry eye. So we'll discuss all these things, because cyclosporin, tacrolimus, although they help in controlling inflammation, they may also do some flare up to the patient's symptoms at times. So there are a lot of nitty-gritties in that. We'll discuss that in a different webinar, and I hope Dr. Parul will join us in that also. So next, I would like to go to Dr. Rakesh Gupta. He's one of our executive, and he has a big practice here. So Dr. Rakesh, any questions that you would like to ask the chairpersons or panelists, and any practical difficulty that you would like to highlight here? Because in practice, managing dry eye is different than managing in institute. So Dr. Rakesh, is it there or has he left? Dr. Shreya. Dr. Rakesh? I think he's muted. Bhaga sir, you can ask Dr. Rakesh to unmute here. Dr. Prabhakar, what is your experience? And any question you would like to ask to the panelists?
One thing that I would like to add is, as we have residents along with us, so for the sake of their understanding, I would like to add that whenever we are examining a patient for dry eye, like we are evaluating them, the first thing that we need to do is that we have to do a non-invasive wake-up time for the first. And that is something that we have to do first, followed by, if we are going for tear osmolarity examination, we can go for that. Subsequently, then we do fluorescent wake-up time, and then the staining, corneal staining, and at the last we have to go for the Schirmer's, because if we are doing Schirmer's at the first, that is going to change the staining pattern. The second thing that I would like to add is, as Dr. Parul said, like I agree with her that direct assessment of tear secretion, DATS, is a very useful test as far as the tear secretion is concerned, and we get to know in real time that there is either deficiency in the aqueous secretion, or there is deficiency in something else. So it directly tells you that whether it is aqueous deficient or non-aqueous deficient dry eye. One more thing that I would like to add here is, while doing DATS, we also look for the delay, the lag time. If the lag time while we apply the fluorescent dye over the supratemporal fornix, and we also look at how frequently or how early the tear secretion can be seen. So if there is a lag time, that also says that there is a component of neurological causes there. Because of that, there is a lag time. So these 2 points I would like to highlight.
I would like to add a component of neuropathic pain. So neuropathic pain is what we call a pain without a stain. So for that, the patient will have symptoms, but will have a normal T-but, will have a normal Schirmer's, will not have staining. So it is a pain without a stain. And to diagnose that, we have the Paracane challenge test. So we put a drop of Paracane, and if the patient feels instant relief with that, so it confirms a neuropathic type of a pain. And for such cases, we have to refer to a neurologist who will probably start on an oral TCA, that is tricyclic antidepressants. And from our side, we can just give lubricants or even cyclosporin.
I'll just add one point. I think it was Praful's question that what is the most basic test one can order sitting in the OPD. So government setup may be a little different because there are too many patients, but in a private setup, apart from fluorescein stain and general examination, the patients can be handed over the questionnaires. There are a lot of good questionnaires, the easy ones also having just a few questions, which gives us a very good idea about the patient's symptom, the quality, how much disturbing the dry eye is for that patient. So you can get a very good idea about the patient's severity from these questionnaires.
Thank you, ma'am. Dr. Sohini Mandal has joined us from LVP. So, Dr. Sohini, you can give us a perspective from your center's point of view, and you can elaborate a little bit about the DART test, which Dr. Parul said from LBP, Dr. Sayan Basu group. And what is the commonest profile that you see at LVP, and what is your approach?
Yeah, Dr. Praful. First of all, I would like to congratulate you to you have taken an initiative of starting this DOS Super Tuesday webinars, and I would like to thank you for including me in this webinar. So regarding the patient cohort that we usually see in Eastern India population is that there are two types. One is the young population who are working maximum 8 to 12 hours of computer screen, desk job, IT guy. And the second set of population is that of retired personnel, be it housewife or retired school teacher, anything. So whenever we are educating about the lifestyle modification, the elderly age group who are in the household, they are often compliant to the treatment options, and they often come for a regular follow-up. On the contrary, the person who are experiencing a computer vision syndrome type of problem, who are constantly on a desk job, it becomes very impossible for them to accept this lifestyle modification of this 20-20-20 rule, taking a break and increase their blinking rate. So it become that what I have faced is that counseling these type of subset of patients about taking a regular break in between their desk job. They often tend to forget to blink. They often tend to forget to take breaks. So I would like to ask that how do you counsel such patients and ensure that they follow this regimen?
I think it just depends on the severity of the disease. If it is really too much and bothering them, they would do it themselves. No matter how much you're going to counsel, if they are comfortable, it's a very mild form of disease. I don't think they are going to really do anything about it. But if it's severe, then they would visit you more often and they would be spending more chair time with you than any other patient would.
Yes, more often they want some magic drug that you give me some drop and it will instantly cure their eye and they become symptom free. And regarding the DATS protocol, it is being regularly practiced in LVP. We often, to differentiate between evaporative and aqueous deficient dry eye, we often invert the upper lid and without staining the fluorescent strip, we directly touch the tip of the strip onto the ductules of the lacrimal gland and assess that how many ductules the lacrimal tear flow is there, how many ductules are working actually. And it is a very useful test that we are regularly being practicing over here. I would
Thank you,
like to
Dr.
ask
Sohini.
a question regarding how commonly do you follow up these MGD patients according to the severity?
We do have a webinar for MGD, Sohini, and I'll take you as discussion in that also. We'll take up this question there because I'm getting a lot of questions from audience. So I'll have to take that up. So, Dr. Divya, this question is directed to you. What is your experience about rebapamide eye drops as a secretagogue?
No, I have not used rebapamide.
Dr. Susaban Das from Uttarakhand is asking. Any of the panelists?
Yeah, I can answer this one.
Yes, ma'am.
This eye drop, in fact, there was a study which was done at our center, and we used this eye drop in our almost 45 patients and as a secretagogue. But somehow we did not get very positive or encouraging result with this eye drop. And in fact, they said that you don't have to add anything else and you just have to use this eye drop. So that way, the patients were not comfortable, in fact, symptomatically also, and when on the test also, they were not showing very good results, despite the fact that many of the studies, they show good results. So in our subset of patients, we did not find any good results. So we are not using routinely this eye drop in our dry eye patients.
Dr. Supriya, any experience of using rebapamide? Dr. Supriya is from Army Hospital Research and yes.
Hi, good evening, sir. No personal experience, but when I was doing my senior residency in PGI Chandigarh, that time it was again a like ma'am just before me said that it was a thesis project by some candidate, and they found mixed kind of a results, not which the kind of results which they were expecting. They didn't find it exactly that sort of a result. So nowadays we don't even get this molecule anymore, and it has been discontinued for quite some time from the market as well for the same reason.
Next question is quite relevant to this class. Okay, so how to choose whether to use CMC or HPMC or polyethylene glycol or sodium hyaluronate? How to choose in which group of patient you would prefer what? And
See, you have to follow a sequence of tests which has been elaborated by many of almost the entire panel of experts and everyone. You have to start from the non-invasive, then go to the invasive one, and probably take Shermer's with a pinch of salt towards the end. And based on that, and keeping in mind that 60% of Sjogren's syndrome people have associated MGD. So it's not that if you have found MGD, you treat only for MGD, you treat only the evaporative kind of a dry eye. If you found Sjogren's patient, your patient is coming from rheumatology clinic, इसको Sjogren है, अच्छा ठीक है, CMC दे दो, ये दे दो. Mixed type of dry eye is one of the most common forms which we see, and so we have to treat accordingly. So if we have found a predominant that, so lubricants like CMC or HPMC will be more for aqueous deficiency kind of a dry eye. And for evaporative, like molecules like Cysteine Complete is there, or mineral oil ointments are there. They'll be of help. And to some extent, sodium hyaluronate has also been advocated in that kind of a dry eye.
So,
So,
Dr. Achin,
based
I hope you got the answer. And also, Dr. Divya said a nice slide, which I was telling
yes,
previously.
tear film
I'll
oriented
share the
therapy.
snapshot of that to you. That will help you in knowing which molecule to use when. We have a question from Dr. Lakshmi Kunyal. Do you prefer to conduct tear film layer testing in all suspected cases of tear film dysfunction? Dr. Divya, this question to you. Do you prefer to conduct tear film layers testing?
Tear film?
Layers testing.
Okay. Yeah, so when a patient comes to you, I mean, you obviously will, you're talking about the OSA analyzer, or?
I don't know. This question's to you, and you'll have to answer this. Do you prefer to conduct
Dr.
tear
Lakshmi
film
is a
layer
retina specialist, so maybe that is why she wants to know. She's doing the OCT for retinal layers.
Oh, yeah.
Maybe that may be the possibility.
Yeah,
Yes,
so
tear
not
film
for
layers
all
testing.
patients, obviously not for all patients. When we have a suspicion there, then we would do it. And again, even mammography, we don't do it as a routine for all patients, because as one of the panelists was mentioning, it's quite expensive. Not everyone can afford doing a mammography. Just looking at the lid margins will give us a good clue. Unless and until you want to prove a point to the patient, they don't agree to what you say, or they don't. They want a better understanding, or they don't mind paying for the test. If they want to get it done, then we would advise an ocular surface analyzer test. But otherwise, I don't think it's routinely needed for all patients. But it's a good way to tell your patient what exactly is happening. And you can also show them, as Dr. Parul was mentioning, and I think Dr. Surabhi also was mentioning. So I would actually make a drawing and show them that this is how the meibomian glands open up, and this is how we are supposed to do the downward movement or the upward movement. So in that case, then it helps. But I don't think I would do a ocular surface analyzer for every patient that walks in.
If I could just add something else, that we have to counsel our dry eye patients, especially the evaporative kind of the meibomian gland disease, which we are, that it's a long process of healing, and it is mostly almost a modifiable disease. It is almost a modifiable disease. It's going to be healed to a great extent, and it is going to take time. So they have to be patient, not only like as a patient, and have to be patient with the disease process in itself. So that is very important. So you have to teach the patients, and lid hygiene, like warm compresses, lid massage, lid scrubs, they have to be a part of their life, their ongoing process. It cannot be just 3 महीना कर लो, 6 महीना कर लो. It's not like that, especially elderly patients.
Thank you. So next question is, sorry, I'm running through the questions because we have to conclude by 9. Efficacy and safety of serum eye drops for dry eye disease. This is from Dr. Tanvi Khosla from Maharashtra. Thank you, Tanvi. People are joining from all parts of the country, and DOS is quite happy to answer your questions. Dr. Divya, any experience of using serum eye drops?
The autologous serum, yes, we do use it on a very rare occasion, but the issue is, the kind of patient profile that we have they're mostly from urban areas. I mean, not from urban areas, but from the rural population. Again, you have to have a refrigerator to maintain the temperature, and you have to maintain those drops well. So for the kind of patients that we might have, we will have it as the last choice of prescribing autologous serum. We do it.
Normally at RPC, we prefer for cases of PED, persistent ectoral defect.
Yes.
And especially post-keratoplasty cases where you expect that neurotrophic factor may be playing some role.
Yeah. And there is
Yeah. What about
epithelial
Farooq and Dr. Shalini? Are they using autologous serum?
Yes.
Ma'am, if you are using autologous serum drops in your practice, that was the question to you.
Yes, we use it quite regularly. especially in cases of persistent epithelial defects and in cases where there is severe dry eye not responding to any of the modalities. But then, as rightly specified, that storage of the drops is extremely important, because once you make, it is not just one eye drop which is being made, there are multiple of them. So we ask them to freeze those eye drops, and the one which is being used, that is kept on the in the door of the refrigerator, which is being used regularly. And then contamination has to be avoided very, very carefully, because it is a kind of culture media for a bacteria to grow. So storage is, yes, definitely it is an issue, but then the response is very good. The patient who don't respond to any of the lubricants, they respond very well to autologous serum. And we are very happy with the autologous serum, especially in these kind of patients where nothing is responding. Any
Thank you,
of
ma'am.
the panelists have experience with plasma-rich, platelet-rich plasma in dry eyes? No? Well, I have seen few of the people, they are using platelet-rich. Dr. Praful, do you
Even
use?
there are, we did a study here, and that is basically same to your autologous serum drops. But few
Okay.
people prefer that, especially in, if you see Western literature, they prefer platelet-rich plasma because they believe the growth factors are more concentrated compared to autologous serum. But at RPC, there was a but the result was comparable to autologous serum. There was no difference.
Okay, so we are using autologous serum.
Ma'am's voice is breaking, so I'll take up the next question. I think this will be the last question. Post corneal trauma, which lubricating eye drop to be preferred? Post corneal trauma.
Yeah, I think something like sodium hyaluronate, which not just acts as a lubricant, but also has epithelial healing properties, is what a lot of studies say. So I think that can be used as a preferred halos.
There are
Yeah.
few questions about cyclosporin, and just to answer that, we'll have a separate webinar for ocular surface diseases and dry eye and immunomodulators in dry eye. So this is not the first episode. We are going to have another 11 episodes on dry eye. This was the comprehensive intro type of webinar. From next onward, we'll cover a specific aspect of dry eye. So Dr. Sisi Agrawal sir from Delhi, and a lot of questions are there about cyclosporin and steroids. We'll take up those questions in our next subsequent webinar. Request to all, please to join this webinar. We are going to do this same dry eye related webinar on every second Tuesday of every month. And thank you, Dr. Thank you, Cipla Pharmaceuticals, for helping us with this series of webinars. And thank you all of the panelists. Nowadays, webinar hardly you get 30, 40. But just to tell you, we have 193 people that joined this webinar at some sort of time. On an average, we have 100 live attendees on Zoom. And on YouTube, there were 50 participants. Maximum it went out to 70, 80, but on an average, 50 live participants were there. So almost 200 plus live attendance was there. So that suggests how successful this webinar was. And thank you to all of you. Thank you, Radhika ma'am, for taking out your precious time and staying with us till 9 p.m. It's difficult to stay for a busy person like you so long. So thank you all the panelists. Thank you, Chairperson. Thank you, Dr. Divya, for that wonderful talk and taking up this lecture in such a short notice. And I hope all of you will join us in our next webinar, which will be exactly 4 weeks after, covering another episode on dry eye clinics.
Thank you for the opportunity and a great
Thank you so much, sir.
Thank you.
Thank you,
Thank
Praful.
you.
Congratulations. Bye-bye.
Thank you, ma'am.
Thank you.
Thank you, Dr.
Dr.
Praful.
Praful, and congratulations. Bye, everyone. Good night.
Good night. Yeah.
It was very nice meeting all of you virtually.